Thanks, Allison. Yeah, super excited to have Matt and Judy involved. I'm honored to be part of the Neurotrauma Care Pathways executive or steering committee. So I've worked with Matt and Judy for the last couple of years in the project, but they've been expertly sort of guiding this massive project along, which they will, of course, talk about today. And it's just really great that we can bring this great work to this group. Matt and Judy, had we taught you guys? We're recording. You just heard that, and you guys are okay with that? Okay, great. Because we get a lot of people who watch these webinars after the fact, so that's awesome. We'll make sure we distribute that. So anyway, let me introduce you to Matt and Judy. So Matt Wiest has broad experience in basic sciences and health systems planning and evaluation. Within healthcare systems, he led and collaborated in local, provincial, and national activities, developing and implementing quality of care indicators for spinal cord injury rehabilitation. Currently, he leads the development and implementation of the ideal care pathways for traumatic brain injuries and traumatic spinal cord injuries in Ontario. And Judy Gargaro has extensive experience working in the fields of brain injury and spinal cord injury as a clinician researcher and quality improvement and implementation expert. She has worked at local, regional, and provincial level with particular focus on ensuring that persons after brain and spinal cord injury receive equitable best practice care and the needed services and supports to optimize long-term care living in the community. Currently, she is a director of the Ideal Care Pathways Initiative for the traumatic brain injury and spinal cord injuries in Ontario. So again, thank you so much. I will turn it over to Matt and Judy.
Hey, hello, everyone. Thank you for joining us here today. So as Jamie suggested, we're going to be focusing on presenting to you and hopefully creating a bit of an opportunity for a discussion at the end on the work that we have been doing for the past 2 years within the Neurotrauma Care Pathways Initiative. So presenters here today is myself and Judy, but we have an extended team, including Armand, who deals a lot with the data side of the house that Judy is going to be talking a bit on the end and at the end of the presentation, and Dr. Mark Bailey, who is the main lead of this initiative. So I think you can guess that we're focusing both on brain and spinal cord injury. We're creating a neurotrauma care pathways agenda, but today we're going to be discussing a bit all what we did, but with a special focus on primary care, because this is webinar series is hosted by the Center of Family Medicine. So we thought had a bit of an opportunity to explore that side in a bit more details today. So let me share my screen. So I believe you can see it now, Judy?
Yeah, it looks good.
Okay. So okay, is it moving? Yeah, okay. So we have Mark has a few disclosures that if you're interested, you can read in this slide. The most important ones, he has an employment relationship with Toronto Rehab, where he's the medical director, but he also serves as some of them funded and other ones not funded. He serves as some chairs across UHN. Judy and I have no disclosures to address at this moment. So out of curiosity, so we build in a couple of polls here, but the polls are going to show more questions that I want to do in these slides specifically. But out of curiosity, can you please fill the current poll, which will ask you a few questions, including, is there an ideal care pathway for spinal cord injury? And by pathway, we mean like a map that details care and services from time of injury to life in the community. Are you aware of such a thing? And the other one, is there a clinical practice guideline for spinal cord injury with a special focus in Canada? Are you aware of those things? Starting to get some answers. Seconds. Okay. So let's see what we got. Can you see the results? So we got more or less 75% of responders suggesting that there is no pathway. And gladly, 73% says there is a clinical practice guideline, or at least there is awareness of one. So these are interesting results. So I will stop sharing. I will go back to the other questions later. So let's see what we have been doing to try to either address one of these questions or to include the other one when addressing these questions. So a couple of patient stories, because there is no need for a pathway or a guideline or any sort of services and supports if the patient is not put at the center of the story. So we put a couple of here just to drive you on the current state and the experiences that people currently have to start to direct us towards what is the difference between the current state and what do we need to reach an ideal state. So this is a story from Lisa, if I remember correctly, and Lisa had a spinal cord injury. She was timely transferred from to a local level 1 trauma hospital. She stayed 4 days in that acute care. She was lucky enough to have insurance to transfer her from the place where she was admitted closer to her residence. She spent 6 weeks at an ICU. But during that stay, she was not really sure why a ventilator was used when she was admitted, and she ended contracting pneumonia in ICU. Once she was done with the acute care, she was transferred to specialized interprofessional care for 7 weeks. Sorry, this was John, not Lisa. An hour and a half from John's residence. He was discharged prematurely because of COVID and only had a week notice before that discharge. You can see how that is complicated when you have someone moving back to, for example, to their own house if the house is not adapted. So there was no assistance. No assistance was provided to arrange transportation. There was not enough education provided before discharge, and there was lack of a timely referral to neurologist after rehab. In the community, he felt that there was not enough financial support. The family and the community, they had to raise funds to support what he needed, including house renovations. He was lucky enough to get support from SCIO to get access to important resources, and he has about 4 hours of daily home care and personal support. Worker supports their family in activities of daily living. If we go to the second journey, this is the journey of Anita. So Anita seems like she had a bit of a more smooth trajectory than John had. She was admitted to a trauma center. She was in a car collision. She was admitted, sorry, the first person, what was it again, Judy? He fell in a golf course, if I remember correctly.
He was attending a golf tournament. There was uneven sidewalk. He tripped on the uneven sidewalk and fell and sustained his spinal cord injury. So he was out of country, not just out of his home city. He was out of country when this happened.
So Anita was in Canada in a car collision. She was admitted to a trauma center. She spent 6 weeks in acute care. Trauma and acute care providers were specialized, so she felt that she was well treated. She spent almost a full year in patient specialized rehab. She had an active involvement in the whole planning of care. Even when family could not really attend the meetings, they were catch up later on. Once removing to the community, she was lucky enough to have sufficient insurance coverage to cover everything that she needed. She needed assisted living 24/7 post-discharge, and the rehab facility and SCIO provided important resources. So slightly smoother journey than John, but she felt that two things were key. So she had challenges with families attending some of the meetings because of the timing of the meetings with the healthcare providers. And she also felt that she had some lack of assessment for brain injury at the same time of a spinal cord injury. So how does that fit in a wider perspective? So if we look at the problem of healthcare provision for spinal cord injury from a broader perspective and from a provincial perspective, we see that some of these challenges are not unique to these two people. They reflect bigger and wider problems across the province. So there are big problems related to timing for initial medical assessment and surgery, especially when people acquire the injury at remoter areas. Access to specialized rehab is a known problem because not everyone lives close to a place that can provide this specialized rehab. And because spinal cord injury is such low incidence, there is also not enough specialized rehab for everyone to attend. The connection to specialized appropriate community services and supports can be complicated, and it can go back to the two stories that we heard. It could be either because I don't have enough insurance to cover the services that I need, or it could be another problem that there are not sufficient specialized services in the community for people to attend. Again, if you're in a rural remote area, it gets even harder. And then you still have a very big problem that is, we are highlighting here for spinal cord injury, but is a problem that reflects across basically the whole care system, which is individualization of care to address care equities. So this is planning for care when you're considering what are the comorbidities of this person, age, social determinants of health, sex, gender, income, what is the population group, do they have food security, do they have income security, do they have traumatic experiences, and so on when planning and providing care. And a big one across all of this is access to primary care. I think this is not news to anyone. I think everyone is quite aware, just judging by broad media posts on how hard it is to get primary care across the whole country. Another thing that complicates care is the way that the model of care that exists in Ontario, and which is quite similar across the whole country. So most of the care in the country is not designed federally. Federal funds are sent to provinces. Provinces design their own health models of care, and which usually goes on having a provincial agency, a broad, big agency or ministry that has a sub-agency under it. In Ontario, we have the Ontario Ministry of Health, and then you have Ontario Health under. Ontario Ministry of Health defines the priorities. Ontario Health implements these priorities. So we have this publicly funded healthcare, but we also cannot forget that there is insurances and benefits that provide some further care and supports. And these are third-party funded and separate from the public health services. Not everyone has access to it, but this system does exist across Canada. So it's complicated sometimes to create a balance between the provision of care and services between these two systems. They are not very well integrated. So what can we do to address these known systems, these known problems within the healthcare systems when providing specialized care for people with spinal cord injury? So we attack this problem from a care pathway solution. So models of care like Ministry of Health and Ontario Health, or the hub and spokes models in the US, are things that are defined by governments to run how funds are going to be distributed and how care is provided. What we needed, in our perspective, was something that can be used independent of the model of care chosen. So we needed to create a clear path or pathway that says what happens to people from time of injury to life in the community across the whole lifespan, not just the hospital. Importantly, what happens after the hospital, combining these publicly and third-party funded care and services. So for that, we used implementation science models where we kind of can divide in between engagement, planning, and piloting. We roughly can define those within the 3 phases of the project, which were the original 3 phases, where we are on year 3 now, which is the implementation phase. So we initially engaged everyone that we could engage, that we classified as key partners, starting with people with lived experience and their families, moving to clinicians, community care, service providers, managers from healthcare systems and outside healthcare systems, planners and funders. And funders include publicly and third-party funders. And we have discussions about what are the current state of the system and what are known gaps of the system. Then we created specific working groups, either separated by care stage or separated by regions or separated by injury or separated by specific clinical subpopulations. And just an addendum here, when I say injury, our initiative focuses not only in spinal cord injury, but also in brain injury. So whatever I talk here about spinal cord injury, we have exactly the equivalent for concussions and traumatic brain injuries, moderate severe. So for all these groups, we put them together to create solutions for the gaps that were identified. And once we had solutions, we tried to move to implementation of small projects to move from current state to ideal. So just going a bit more in depth on the first 2 stages, that was engaging in planning. So we had these structures with all these key partners distributed across Ontario Health regions, distributed also in specific clinical subpopulation working groups. Here are just a few of them. We cannot address everything at once. So we started focusing on some key priorities that also align with Ontario Health priorities right now, which is older adults, mental health and addiction, and Indigenous health, all discussing the current state of care, gaps and inequities from this perspective of these working groups, and then trying to move towards creation of an ideal care pathway. This ideal care pathway was strongly based on clinical practice guidelines, especially the Canadian Spinal Cord Injury Practice Guidelines. So to question number 1, question number 2, do we have clinical practice guidelines? Yes, we have an excellent one that is developed in Canada, is a living guideline that is really comprehensive from time of injury to time to living in the community. So this is an excellent resource that if you want to scan that QR code, you can get access to that practice guideline. That practice guideline is not perfect yet because it's a living guideline. So some structures, although we may have some evidence, they are just not summarized yet. So we used other guidelines like the NICE from the National Institute for Health and Care Excellence in the UK and the Paralyzed Veterans of America to just fill some small gaps that may still exist on the Canadian guideline. But the Canadian guideline is our main source of reference. We used all of that allied with the experiences of our key partners to develop the ideal care pathways. So because this is for brain and spinal cord injury, the first thing that we did was to create a summary pathway that describes in general how the system, what are the stages and the key parts of the system, which is obviously pre-acute, acute, rehab, and community, the care stages. With team-based primary care being identified as a crucial role because the largest stage of care is the community and the team-based primary care. Considering the complexities of spinal cord injury, you need a team instead of a single healthcare provider to provide the optimal care for this population. And in the bottom, we have the equity considerations, which we thought that are fundamental to individualize the care map for each person going through this care pathway. Then we went in depth, what are the elements of the pathway that are needed if we look from a very broad and more detailed perspective. So you can see on the right side of the screen the whole pathway, but there's no expectation that you can read that. So I broke it down in 2 halves. So I literally just cut the figure on the left in 2. So you will see here that there is the distribution of these stages of care. They exist. There's a way that I can put a pointer somewhere. Anyhow, they're broken down in pre-acute, acute, specialized, and community, and you're going to see there is a bunch of boxes under, and these boxes address the content of the clinical practice guideline, the large majority of them, and some of them fill gaps identified by people with lived experience and their families. So it's quite clear that assessment and management of a spinal cord injury is a very comprehensive content in a clinical practice guideline. And if you could open this box, you would be linked to the appropriate sections of the clinical practice guidelines. If you look on the middle here, you have support for family and friends. This is not something that is really well addressed by any clinical practice guideline, but there is a ton of content, for example, developed by Spinal Cord Injury Ontario. So these are resources that exist that are listed inside this box. If you want to see an interactive version of this pathway where you can go in and out these boxes to see what is the content of a clinical practice guideline of what resource exists, you can go to our website using this little QR code at the bottom. You can see what is the content, the linkage. So to question number one, is there a pathway? Yes, there is. Here is the pathway that we identify for Ontario, which is linked to the second question, are there guidelines? Yes, they are linked within the content of this care map, this care pathway. We also published, we just got accepted on topic of spinal cord injury rehab with a manuscript that is going to describe the details of the traumatic spinal cord injury ideal pathway of care that we develop within our activities. If we go a bit, if you want to see our website, here is I put a screenshot of our website, and there is a QR code to get access to that website. And just moving a bit more in depth on the, just to show how the consultation with the regional priority groups went. We distributed our regional working groups because we wanted to know these care map, this ideal care pathway that we produced, it was mostly produced from a provincial perspective, but we had to make sure that this care pathway can fit different regions of Ontario because they are different. There's density differences, there is availability of services differences, cultural differences. So we have small consultations with which one of the 6 Ontario health regions, and we got 2 main themes that came out of that. One of them, we need more education and training for everyone involved, healthcare providers, primary care providers, including primary care providers, people with lived experience, and caregivers. And we also got a big theme behind that was navigation and coordination of services. So now that you see that we do have an ideal care pathways for traumatic spinal cord injury, it's also important that we have ways to evaluate the current state of the system and to measure how each part of the system is doing and how can we move to ideal state. And also what we are doing is also important to do something to move from current state to ideal. And Judy is going to be talking about these 2 things and including our next steps in our process.
Thanks, Matt. So if we go to the next slide, you'll see that there's the little map of the pathway that Matt's already talked about. And so one of the strengths, I think, of the work that we're doing is that we've acknowledged right from the start that the pathway is going to be stronger if we build in these quality indicators that are required to evaluate how the system is doing. And while the work has been developed in Ontario, it's actually based excuse me, in clinical practice guidelines that have international relevance. And I think certainly across Canada, the pathway is relevant the way we have built the building blocks. So the indicators were developed with our key partners, and Matt alluded who those were, and they were defined. And so when we talk about defined, this is really indicating what the data sources are, who's doing the collecting, what the data collection mechanisms are, who has access to the data, and what some of the implementation challenges might be when looking at these quality indicators. So we came up with a rather large number of indicators. So obviously there's only so much capacity that a system has, or even individuals have, to manage indicators. So we recognize that while there are 67 indicators that are mapped onto the pathway, across all stages, that probably we needed to go through a prioritized exercise to really say, what are the ones that if you do nothing else, you need to do these? And so we came up with 22 sort of core set of quality indicators. And out of this 22, there's 10 you can see that we've classified as new. So I'll get to what that means in a minute. So you can see in this table, this is how we've mapped the 67 onto those stages of care that you see in the diagram above. So equity is there, and then pre-acute, acute, rehab, and community. So you can see the core set cuts across all of these stages. Then we have the must-haves, which we think are, if they're not essential, they really should be there. The should-haves and the nice-to-have. But I mean, ideally, we'd have all 67. So a couple of things to notice that the group really felt we needed to do a much better job of evaluating how we were doing on equity. But you can see that as much as there are many indicators for acute, there's actually quite a few for community, in fact, more than rehab in there. So we're really highlighting that each stage along the care is important. So if we look at the core set, so there's 10 that are really already being collected in administrative databases. So that's the low-hanging fruit. But there's 3 that are being sort of collected, whereas some people might be collecting some of the data, but the data is not really well integrated together, and it's not being collected well over the different silos of care that Matt alluded to in his early slide. And there's 9 where there's actually no mechanism that currently exists. So we need to develop those mechanisms to collect the data. So that points to how much work is needed on the data side of the house in order to even implement and report on this core set. So the next slide, you may wonder what we're talking about when we talk about quality indicators. So I've just come up with a couple of quick examples, and you'll see here that this is traumatic spinal cord injury. And while that's important to indicate, because we're going to be presenting some data in response to these quality indicators, we don't really feel that the pathway is exclusive to traumatic injuries. There clearly may be some adaptations that need to be done for non-traumatic injuries, but fundamentally it's the same. So at the pre-acute side, we can look at incidence rate per 100,000. Of course, adjusting for age and sex. At the acute stage, we can look at, again, risk-adjusted mortality rate. When we get to rehab, it's important to know who's going to rehab. And you'll notice we've stipulated here specialized inpatient rehab, because we know as much as we, I think many people would ideally say it's nice to go to specialized rehab, there's general and even neuro-focused rehab as well. So it's important to see who's getting specialized rehab. And then in the community, we know that it's important to have follow-up. And again, Matt referenced the clinical practice guidelines, and the guidelines talk about the value of follow-up, by either a family doctor or some sort of physical medicine specialist like a physiatrist. All right, so if Matt's now going to put up our next poll. And so these are going to be questions 3, 4, and 5. So you'll recognize the previous poll. But if you want to just scroll down and you can answer questions 3, 4, and 5. Some people already have.
They got all the questions at once. So those are answers. So those are the results.
Okay, these are the results. So everyone got ahead. Okay, so what do we see? So the general feeling is that, around half, most people are sort of sitting at sort of around half of people get access to specialized inpatient rehab. So that's actually kind of an interesting response. You guys are a very educated group, clearly. If you look at how many people see a family doctor in the community for follow-up, most of you are sort of in that 60 to 80% of people are follow-up. And again, gosh, have you guys actually seen the data? You're very astute. And then if we look at how many people have seen a physical medicine specialist, the majority are saying that about a third of people have seen a physical medicine specialist. So let's actually see how that relates to the data that we've been able to collect. And again, this is Ontario data that we were able to collect. So again, looking at that incidence, just looking at the fiscal year of 2020, 2021, and I'll highlight for you most people will recall, this was year 1 of the pandemic. So if that number doesn't seem to make sense to you, it's probably because it was the first year of the pandemic. So in that year, there were 389 traumatic spinal cord injuries in that fiscal year, which relates to an incidence of 0.01 per 100,000. When we look at who those folks are, they're primarily urban males over 40. If we think about the role of primary care, obviously it differs over the lifespan. It's important to have a pediatrician when you're young, but as you get older, I think the need for primary care becomes more important as people tend to have more comorbidities that happen as part of aging, or some of their bad habits catch up to them. So there's more of a need for primary care. So looking here, the majority of people are getting into an older age where they may naturally have a lot of comorbidities and things going on. So I think it puts the burden more squarely on making sure that there's appropriate primary care follow-up. If you look at mortality, relative to stroke, the mortality rate is a little lower. So I think that's a good thing. For rehab, about a third of people get access to specialized inpatient rehab. So it's not quite as good as you guys felt on maths, but you were close. If you compare this to brain injury, spinal cord injury looks brilliant. Frankly, most people, when I show these stats, look at that brain injury stat, and that really concerns them on how low it is, but that's a separate presentation for a separate day. When we look at the community in terms of follow-up, so these are folks who had rehab. And I have to say, we did collect data on folks who didn't get access to rehab. So these will be people who just go straight from acute care. And interestingly, those percentages are much less for follow-up with family doctor. And you could rationalize that that's because the injuries are less severe. But the flip side of that coin is they didn't get access to rehab. And so they probably should have a follow-up because it might not be clear some of the needs that they have now that they've been in the community that may not have been evident during their acute care stay. So, 72% of people are getting a follow-up with their primary care provider within 30 days. And on the specialist side, we look at that within 180 days, just because it's not realistic to look at specialist follow-up within 30 days. And a vast majority of people have follow-up. Now, again, if you look at those folks who've been discharged from just acute care, the percentage is lower, and it makes sense that it's lower, but it's probably shouldn't be as low as it is when we think about some of the needs for seemingly mild injuries in acute care don't always end up being that way when people get back to the community. All right, so moving on to the next slide. Quite a few people have published in this area of the role of primary care. And so I highlight a paper that Chester Ho, and I see Hope, who's working with Chester on looking at models of care for spinal cord injury. Chester published a really great paper in 2016, sort of looking at primary care, not a novel idea, but it's still underdeveloped. I think his paper is very relevant now. And obviously, we've been really focusing on the fact that spinal cord injury is a chronic condition and that things do pop up over time. And so that's another good paper, Chronic Complications of Spinal Cord Injury, that really outline the areas that are important to be on top of in primary care. And then the third article there from the British Journal of General Practice, the focus is a little bit more brain injury, but as we know, folks with spinal cord injury often also have concurrent brain injuries, often a concussion, but also it can be more of a serious brain injury. That paper is very interesting because it it indicates the importance of general practice follow-up after patients have experienced trauma. So those are there for your reference. So what have we heard about in terms of primary care after spinal cord injury? And I've grouped the points in sort of 3 big chunks. So, obviously there's some structural things we've heard. There's not enough people who are available to see patients in general, but also who have spinal cord injury in terms of accessibility standards in buildings and within offices. There's also sort of a model of care issue in terms of team-based care really seems to be a recommendation, because as much as specialist care is needed. There's also specialist generalist care as well as generalist care. So we need to create some capacity. Also, spinal cord injury is a chronic condition, and billing codes for payment need to reflect the fact that maybe 15-minute follow-up isn't quite where you need to go with someone with a chronic condition who might also have multiple comorbidities. And then the last bit really talks about how primary care exists within a system. And so, you know, the concern that there needs to be more access to system navigators or regional service coordinators, but also there needs to be seamless and easy transfer of information from one sector to another. So that's what we've heard. So what are we doing about it? So we have these 6 implementation projects on the go, and it would be nice if we had a whole lot more, but as people who know me know, I say this a lot, you can't boil the ocean. You really have to start one pot at a time. So we are starting with these 6 projects. These are all projects that have received a small stipend from the project. They are working now, and they have to be finished by February. So these projects were chosen because they fit into the priorities that Matt referenced earlier, and that they were all something that was doable to be done by the end of February. And it was a good start. So there's one in each of the 6 regions of Ontario. You can see there's some things that are very relevant for primary care, but I would argue all of them have a relevance to primary care. So the first project is actually looking at an implementation of a primary care visit checklist. And we are also going to be connecting them with Jamie, because again, part of the purpose of these projects is not to reinvent the wheel. If there's other good work that has been done across Canada, then we want to connect people together to link them so that they can riff off stuff that's already been done to improve things in their area. We also have a second project looking at the spinal cord injury map from admission to discharge, and obviously there's important connection to primary care as part of this project. Developing and implementing PTSD training. Again, this is really important when you're looking at how people need support in the community. And again, there's a service resources one focusing on brain injury, but also very relevant to spinal cord injury. Concussion referral pathway doesn't appear to relate to spinal cord injury, but again, there's going to be some learnings there around connection to primary care and the value of these kind of care maps, and looking at mental health training. And again, that's focusing on getting people from rehab into the community. So these are just a sample of some of the projects. Next slide. So next, if you wouldn't mind. So we've talked about how we developed the pathway with emphasis on team-based primary care. Next. And you saw that we have these implementation projects, which I've just summarized. Then there's also a 4th element there. In Ontario, there's a real push to develop Ocean e-referral network. So this is the idea, is that every primary care provider, whether they be a standalone primary care provider or part of a family health team, that they would get on this e-referral network, and this will help push. It'll have a push and a pull component of keeping track of referrals and making better links. There's also parallel activities. So I referenced some of the work that Jamie's doing, but also there's work that the consortium is doing in terms of best practices and quality evaluation of specialized rehab, but also they're doing some follow-up into the community. So we're linking with them and keeping track of what they're doing. Also, in terms of what we're doing traveling roadshow. And so I suppose this in a way is part of what we're doing. We're doing lunch and learns and webinars for different groups. So just to highlight, we're not keeping it specific to spinal cord or brain injury all the time. We kind of mix it up to talk about each injury and then also generically. So you can see we've got some talks coming up. We've really reached out to try and get in touch with everybody who might possibly be seeing a patient or a client with a neurotrauma. And we've been wanting to highlight for them the clinical practice guidelines and their role in the pathway and the work that we've been doing on the pathway and the quality indicators. On data, we're publishing report cards. These are Ontario-based, using administrative database and supplementing with questionnaire data where we don't have administrative databases. So that gets at some of the gaps I referenced earlier about data. And so the first SCI report is going to be coming out at the end of this year. And then we're also going to be doing another one that we will release in 2024. So that's what we're doing in terms of trying to communicate what we're doing and the relevance that this work has to different clinical groups and service providers. Next. So in terms of our implementation visioning, just as we move forward, we have projects at provincial priorities. If you want to click that. Matt's driving the slides for me. So this is where we'd be focusing on common gaps, and we would have sort of broad collective projects where people all across the province would work on it. So the Ocean e-referral has a bit of a potential of being that type of project. We have regional cross collaborations. So this would be where there may be a couple of healthcare providers within the same region who are working collectively on the same project. So we're trying to connect those people together through summits and communication. And then we have local priorities. So you saw how we're starting with 6 of those sort of things. And we've had great interest and engagement with these initial projects. And we're creating opportunities for additional projects to riff off these ones, but also expansion and to continued work on implementing across the pathway. So all of this is going towards equitable care and gap elimination. And we're doing this with a focus on optimizing recovery and productivity of people close to family and friends so that they're not forced to be removed from their support systems. And we're trying to do this with minimization of secondary complications, obviously minimizing need for institutional care and minimizing reactive health and social interventions. And again, primary care plays a really important role in all of this area of minimization and optimization. The next slide. And I want to get to some questions quickly. In terms of our initiative progress so far, Matt alluded that we have had done 3 years. I'm not going to read everything here. We're happy to provide you with these slides. But the point is that we've focusing on implementation in year 3. One doesn't do implementation in 2 seconds. It's a multi-year investment, especially for a project that is as large a scope as we've got. So we are in conversations with the Ministry of Health, who is our funder, in terms of the ongoing needs for implementation to continue to leverage what we've already done. Next slide. So the take-home messages, team-based primary care is fundamental in the pathway. There are specific clinical practice guidelines specifically for spinal cord injury, but also for brain injury on the parallel side of things. And we do have a pathway that you can access using those QR codes. And there are indicators that are mapped on the pathway. So whether we're doing them systemically through report cards or individually, people have access to those indicators if they want to work on them in their local setting. And primary care providers, you're not alone. We hear this from a lot of primary care providers. Providing care for someone with a chronic injury with complexity is intimidating, and you're not alone. These are all resources that are available in terms of SCIO. There's Skyer Professional, and there's the SCI Consortium. Again, a lot of this developed in Ontario, but not exclusive to Ontario. Next. And if we don't get to answer all the questions you have, you are welcome to contact us, and you can follow us on, I guess, what am I supposed to say, X, at Neurotrauma Path and at Doc Mark Bailey. So I think with that, I think that's our last slide. So we'll turn it over to questions if there are any.
Yeah, thanks so much, Judy, Matt. A great presentation, a lot of info. Which is, just highlights the work you've done. So I will open it up. Either people can ask questions directly or put anything in the chat.
Hi. Hi, Jamie.
Hey, Heather, go ahead.
Hi, everyone. Sorry, I've got 2 screens, so I'm looking this way, but I should be looking this way. I just want to say excellent presentation. I found it fascinating. Judy, I totally agree. Let's boil the ocean. But let's take small bites first. My question is, in terms of the data set that you presented in looking at the 2020-2021 data set, would you perhaps rather want to look at something a little bit older so that we don't have the impact of COVID?
Oh yeah, we just for the point of this presentation, we did tip of the iceberg. So we actually have 6 fiscal years of data, and
Okay.
we've created a data pool where every year we're adding another one. So it's going to end up being 8 years of data by the time
Excellent.
we're done. So because of spinal cord injury incidents, there are some indicators where we have to look at it across years because the numbers are not sufficient to do year by year. So we have data year by year, and we have it across the 6 years.
And are you noticing big fluctuations, or was there a massive impact in terms of COVID?
You know, interestingly enough, there is an impact of COVID when it comes to incidents, but when you look at proportions and length of time, the impact wasn't as much as one would have thought. I think there was a little bit of a push to get people faster out of rehab. So there is a bit of a difference during the COVID years to push people into the community faster. The incidence numbers, there's definitely a reduction, and very apparently on the brain injury side of the house. But there's definitely a reduction. But many of the other things are fairly stable. So when you look at percentages of people getting to specialized rehab, fairly stable over the years. And length of stay a little bit shorter actively during COVID, but again, not drastically different.
Mm-hmm.
Sarah just posted a good publication in the chat.
Yeah.
Also important to notice that a concussion, you sometimes can choose to go or not to go to the hospital. It may not be a good decision not to go to the hospital, but a spinal cord injury, usually if you have one, you probably have to go to the hospital, right? So that's why incidence probably doesn't vary too much.
Yeah.
While you guys think about more questions, I think it's important to mention also some resources that we did not list here in our slides, but Praxis has a ton of resources if anyone needs. And it's also, I think, interesting to mention the work that BC and Alberta are doing to create a BC journey, patient journey, which is similar to our pathway, is actually based on our pathway. So they're moving towards the same direction. And Hope, who is here in the talk, and Chester are leading a national strategy to see how things fit from a national perspective. But also we are participating in that activity as well. So it's interesting to keep an eye open for those things.
Judy, you mentioned ocean e-referrals, and for some people who may not know what that is, and I think you did give a brief description, it's an electronic referral that primary care providers can do to specialists and facilities like imaging and that sort of thing. And I think that highlights a big issue that you guys did talk about as well, and that's sort of the system inequities that, you know, we always talk about how COVID exposed system inequities within healthcare, but complex conditions like spinal cord injury and brain injury have always exposed these issues and the breakdown in communication and the fragmentation of care and that type of thing. What is your, I guess the other side of things, and the e-referrals come into this, but virtual care and, you know, electronic care and that sort of thing, what kind of proposal do you have in the pathway for that? Because I know we've talked about it at the, you know, steering committee and working group level. What's your thoughts on that? Because actually in some places like Ontario, they've actually taken a bit of a step back in how robust that's been since COVID.
Yeah, I mean, I think one of the things that we tried to do in the pathway is put those fundamental building blocks of care. We didn't really talk about how that care would be, the mechanism of the delivery of care. So we sort of leave it flexible to account for different things. So, I mean, obviously virtual care, you have to have the technology to do that and the bandwidth to have that be effective. But so we've said it's important to have team-based primary care, for example, but we haven't said it has to be in person. We haven't said it should be hybrid. We haven't said any of that. We've left it open for those mechanisms to develop in terms of what works really well. I think one of the things that we have called out, and I think most of the guidelines are calling this out now, is this idea of when you have specialist knowledge and then you have generalist knowledge, is how you build some capacity in folks with generalist knowledge. And so I think this is where virtual care at the clinician level is really helpful, because it helps build capacity. And I know there's an echo model that I know there's a few echoes operating on the brain injury side of the house. But this is an example of how people from all across an area can get access to specialist knowledge and apply it to their local practice. So I think moving forward, it's going to have to be a hybrid. When we've heard from people with lived experience that they by and large like it, under the conditions of when they already know the person who's on the other side of the camera. It makes it easier to do virtual care. They often like the first appointment to be in person, so they get to know each other and have that assessment in person. But most people really like no travel time and taking less time out of their day. And certainly if they have a brain injury, you know, or it's physically exhausting, they appreciate it. So we've left it open in terms of the actual mechanism of delivery, but we've just said the element has to be there. I don't know if that answers your question.
If you look at the box, when it says assessment, it says either in person or virtual, especially in the community side of the house, because we don't want to set the stage. It has to be one or the other. It could be depending on the model of care of the province. The province right now is willing to fund that and scale that. And there is an opportunity to do that well, and the patients want it. So yeah, let's do it. If the priority changes, we cannot. That's why we try to focus to create a system that guides any model of care, not necessarily a model of care that is going to be very hard for a government to uptake. It's hard to tell the government what to do, but it's easier to just create a general idea of what is needed, and then they can make the decisions on how to go.
Yeah, that is smart. I mean, it has to be flexible. It has to suit the needs of different geographies and everything, and basically different Ontario health teams, right? There will be poised to institute things in the way that will fit them, but you lay out the map. Yeah, that makes sense. Vanessa?
Thank you. And thank you, Matt and Judy, for wonderful presentations. It's incredible to see all the work that's been done. My question's around, we know that people with spinal cord injury often have a concurrent brain injury. And just wondering around the synergies that you saw by looking at TBI and SCI, if you're seeing a lot of overlap and there's a lot that can be learned from each, or if you're actually seeing it's actually two bodies of work that you need to kind of run in parallel. So just very curious, because we often talk about the overlap, and just wondering what overlap you've seen and opportunities in that area.
So if you were to actually put the brain injury, the concussion is a little different. So let's just talk moderate to severe brain injury and spinal cord injury, the pathways next to each other, you would notice that they're actually pretty similar. So that in terms of synergy, there's lots of it. In terms of those key elements of care that, as we've talked about, the pathway sets out the elements of care, but not the model of how it should be delivered. I think there's a lot of synergy. The reason we are combined in this project is exactly for that reason. And even though concussion is a little different, it's not different enough to warrant a separate. Like there's enough synergies in terms of the key elements that need to be there, how things need to be thought of. Certainly when you have a concurrent brain injury and spinal cord injury, if someone was to, that's one of the things that we'll build out. I noticed Craig has a question on what's on our wish list for future work. One of the things is we're continuing to flesh out adaptations to the pathway. So that is an area when we look at Indigenous health, justice involved folks, folks with mental health comorbidities, aging. There is some work to do to flesh out the pathway to pull out those adaptations. So concurrent injuries is part of that. So that's part of our future wish list, and continuing the implementation. And really, we're having conversations with our government on this side of the house, and there seems to be an acknowledgement and a recognition that neurotrauma does need the kind of care that, let's say, cancer has, and stroke in terms of having more of a provincial strategy that may have a regional focus and more local tweaking, but that needs to have an overarching guiding. So we'd like, on my wish list is to get the provincial government to sort of fund this beyond a project and to see it having long-term, so that we can continue to implement at all those levels of implementation, local, regional, and provincial, to just move this forward and to link those siloed databases so we can actually get a report card that addresses across all of the care, not just publicly funded care or, you know, one specific injury.
Okay, well, with that, it's 1 o'clock. I want to thank everybody for attending, and especially thank Matt and Judy for just a great presentation.